Okay, thanks very much. So I want to actually provide some data and some scaffolding theoretically around the importance of the role of parents and partners and siblings and children and so forth. Whenever I know that sometimes we see the word in the development of BPD or the maintenance, and that could start to feel like somebody's going to get their finger out and wag their finger at somebody, and I assure you I am not. And I hope that will make sense as we take a look at the different pieces here. So I want to start just by acknowledging that in the world of psychopathology, for the last 40 or even 45 years, there have been very good data to tell us that there are important links between individual psychopathology and family distress and family dysfunction, or problematic family interaction, depending on what keywords you search for in the literature. However, until very recently, very few of these have been BPD specific. Now, what that means is that there's a clear, I would say today, we understand a clear bidirectional relationship between the distress on the individual side who has BPD and the partner or parent or other family distress of that person's family. What little attention, however, very little attention has been paid to that process. Now, part of that is because it's so intuitively obvious. I think some of you in the room are young enough to maybe never have had this experience, but frankly, I doubt that. That when you're having I'm just going to say a lousy day, you don't have to be clinically depressed or have a clinical anxiety disorder or substance use disorder, but when you're having a really lousy day, that might have an impact on your loved ones around you and your relationships with them. And when our relationships don't go well, especially whatever important relationships, close relationships we have, it drags us down. And this is just a given. Unfortunately, for many, many different reasons historically, we've tended to think about these two things from a research standpoint as entirely separate. We talk about individual psychopathology, and of course these days we talk about the brain, and our NIMH says that these are brain disorders. Well, of course they're brain disorders, and there are other things too. They're not only brain disorders. We could also say they're relationship disorders, because they are, but they're not only relationship disorders. So I want to talk about this in particular with respect to BPD as a bidirectional arrow. The other reason we got bogged down 40 years ago, frankly, is because we didn't have good statistics. And so people actually argued, many dozens of people got tenure arguing that this arrow only went one way, or only the other way. It's 2018, folks. Let's admit it. The arrow's got it's a two-headed arrow. It's going both ways. That's not complicated to understand. That doesn't mean it's even. It doesn't mean it's evenly 50-50 going both ways. But there is this reciprocal influence. And I would say that the data supporting that, even with the most biological of disorders, is true. And even in the most dysfunctional families is also true. So let's think about this. So I started being interested in this when I was in the second grade back in the 80s. Okay, maybe I was, okay, never mind. Anyway, this is a study that I participated in before I went to graduate school with my bosses, Gabor Keitner and Van Miller at Brown in the medical school there at Butler Hospital. And this was, we're sort of curious about this relationship between family functioning and individual psychopathology. In this case, mostly depression, although the inpatients with depression in those days turned out to were very well represented by BPD, although they weren't selected for that. This is a complicated slide. Let me simply say that what this shows is these are all severely depressed inpatients. And what's different between the red bars going down and the yellow bars going up, the difference here is family functioning. But it's not overall family functioning. It's within the family. Is the family minimizing and denying the family's problems and blaming the patient? This is all your problem. You're depressed. You're an inpatient. If that was true, they were much more likely to have made a suicide attempt. Okay. On the other hand, if the family said, "We've got problems," we've got stuff to do here. It's not just you. You're representing us as an inpatient, but we got work to do too. Just as depressed, depression severity was the same, but they end up without being suicidal. Okay, so this is actually published a long time ago. But this sparked my interest in this relationship going back and forth. And so, and actually I think speaks a little bit, hints at BPD because BPD was well represented here. Now, so we'll roll the clock forward a few decades and say, okay, so here's just one of now many, one of a few studies where we can actually look within BPD or BPD related kinds of samples. So a study one of my doctoral students, Chad Schenk, and I did is we looked at parents of clinic teens, and we picked clinic teens who met criteria, either met criteria for BPD or were very close. And then we compared them to a community sample, reached out to the community and got kids who had never had any contact with the mental health system at all, nor was there any indication that they should have. And we brought them into the lab and left the room and let the parents and the teens have conversations, and we got people who didn't know anything about them to rate a variety of things, in particular how validating and invalidating the parents were. Again, not to blame parents. These are more dysregulated kids on the yellow, and the parents of those more dysregulated kids, as you can see, are less validating, that's the yellow on the left, and more invalidating, the yellow on the right. Or, to look at it differently, I don't have a pointer, sorry about that. The yellow to yellow, okay, they're much less validating, and as opposed to blue, the community sample is much more validating. And we've replicated this with adults and couples, so now within the BPD sample, we actually have good data to say, yeah, not surprisingly, BPD is not at a general level different from other forms of psychopathology. Some early work that Perry and Chilhooly did said there may be some nuances that are different, like with respect to closeness within the family, but overall these relationships are the same. Now, if you ever had a teenager yourself or worked with teenagers, I'm on my 4th teenager, okay? Actually, he doesn't do this at all, but I'll pretend that he does. This is the kind of situation, I can see you, I hear you, but I can't comprehend you. Bridging that gap, of course, is a lot of what we're trying to do. So in DBT, which of course I run a DBT program for teenage boys who have very severe problems, and in DBT we do a chain analysis. Chain analysis just means we look at something happened, there were some vulnerabilities, and then the person has got different thoughts and emotional reactions and other things happen that lead to increased dysregulation and then eventually some dysfunctional action, like a non-suicidal self-injury or a suicide attempt or substance use or maybe punching a wall. That's actually not uncommon in our sample. And then there's some reinforcing consequence that could be private in the sense of relief or public in the sense of somebody in the social environment does something that actually, in other words, you say that behavior works. So when we think about this relationship between parents and teens, or partners and partners, what we're really talking about is that there are specific things that might be relevant that parents and partners and other family members do. They often can show up as prompting events, nagging, complaining, criticizing, invalidating, having a conversation with a mom on the phone, and she said, I couldn't help myself, I just said, he's in a residential, the kid's in a residential program, he's chronically suicidal, he's miserable, but he was complaining and blaming her, so she said, I couldn't help myself, I just said to him, well, if you just got off your ass, you'd probably feel a lot better. Basically this is your fault, and, you're, some other choice words that I won't mention. She said, and then, now she's saying, I can't believe I said that. I said, well, how many times have you said that? Oh, yeah, well, maybe hundreds. And I can't believe it each time. Well, why? Because she's dysregulated each time. She's out of control too. And of course, he's saying awful things to boot. So anyway, so we can think about parents and partners as being prompting events, but we can also think of them as providing social reinforcing consequences. really well done study by High Hops and others in Oregon 30 years ago showed that in couples where there's a depressed, in heterosexual couples with a depressed wife, that depressive behaviors got shaped up over time by if the wife showed more depressive behaviors, the husband backed off criticism. Okay. We call that negative reinforcement, right? But what an awful situation to have to be depressed to get the other person to stop laying into you in a critical and nasty way. Yet that's, kind of what happens, and subsequently followed up. Other studies have shown that, in fact, if you change that pattern, if you actually withdraw the criticism, the contempt, the negative responses, that actually depression goes down, which is why couples therapy is just as good a treatment for depressed women in distressed relationships as CBT, and actually has less relapse than any medicine or other CBT. So it's very relevant to what we're thinking about here. So in DBT, we make things more complicated. We have a double chain, right? Because, of course, in the previous chain, I'm just showing you, say, maybe the teenager's chain, okay, and then maybe the parent does something that prompts it, maybe reinforces some dysfunction. But that means that the parent is also relevant to saying something, doing something, but the parent has thoughts and feelings too. And mostly both people are ending up dysregulated. Okay, at the end, this giant, this busy thing here is everybody being dysregulated, and then the red is people are saying this, very unhelpful things. And then they both go off to their various corners. One of them going this direction, going up, hurt feelings, further dysregulated emotion, and further dysregulated behavior. The other one going this way. And in fact, sometimes we find two people doing fairly dysfunctional things later on. So we call this, of course, a transactional model, the idea of reciprocity, that what one person does affects the other, what the other does affects the one. And remember that double arrow going both directions? The question, well, what is the process? Well, one key piece of this process, at least with BPD, but we've got evidence that it's not just BPD, is that it's the emotional dysregulation in one person elicits and contributes to the other person failing to understand and responding in an invalidating way. And of course, what happens, I know everybody gets up in the morning thinking, maybe today will be a great day. Maybe I'll get invalidated like 30 times. What a good day that would be, right? We all know intuitively that that's really unpleasant. I'll come back to that. So just to stretch that out a little bit, so something happens, and then for the individual, right, the first three sources of dysregulation are the event itself contributes, right? Something you don't like, right? You miss your bus, your alarm is, you're late for work, somebody that you like says something unkind, somebody that you like cancels lunch, something happens. And then there are vulnerabilities like you're tired or hungry, just have a temperament, right, that's more sensitive and more reactive. And, of course, how we process it cognitively if we get judgmental. Those all contributed to this middle box of high arousal emotionally. That judgment arrow goes both ways because we also know, we've known this since 1908, that when our emotional arousal gets high enough, our cognitive complexity goes way, way down, and we become on or off, all or nothing, black and white, threat, no threat kinds of thinkers. So when arousal goes up, even if the person wasn't judgmental, the person becomes judgmental down the road. And of course, the person might be judgmental in the first place. So now we have arousal. Now most models stop here because, okay, this is the individual. The individual is the self-harmer. The individual is the person with BPD. That's all we need to know. The individual then engages in dysfunctional behavior. And of course, the old model said, and maybe does things like angry outbursts or withdraws that are hard in the relationship, or as Perry has articulated, does other things like self-harm or suicide attempts that have a big impact on the other person. But forget that there's reciprocity. So let's look at the next step. So the patient is dysregulated and then expresses him or herself inaccurately. Now, of course, the inaccurate expression is usually something that sounds very judgmental, like you're a big jerk, it's all your fault. Or, no, I'm not feeling miserable. Or, expresses an emotion that actually isn't connected to the event, but a byproduct of something else, maybe judgments. And of course, when the patient does that, it's very hard to understand because it's inaccurate, right? Or as Mary Zanarini has been known to say, when the patient hits herself in the face with a hammer, it's very hard to translate that into, I was really lonely, right? That's very inaccurate expression. So dysregulated actions are also problematic in inaccurate expression. And so the person, the parent or the partner, doesn't understand and is now at high risk and vulnerability for invalidating. But of course, that person has his or her own judgments, his or her own emotional arousal, his or her own vulnerabilities contributing to that, or maybe buffering against it. Okay, but if it's big enough, if the misunderstanding is big enough, the person's probably going to be invalidating. And as if you didn't know it already, we have good data that says, well, if you stress people out, okay, we actually put people in stressful situations. They agreed to this ahead of time, of course. And what they didn't know in this study was that they were randomly assigned to having an experimenter that either validated or invalidated their distress. Okay, so if they got invalidated in their distress, that's the red line. They're in this stressful situation, they stay distressed. If they're validated by a stranger, the experimenter, their negative emotion comes down, 3/4 of the way down. And this was measured not just in self-reports, but also with vagal tone and respiration and skin conductance. So a bunch of different ways, all saying the same thing. So that's the fourth source of arousal. When you get invalidated, that contributes to further arousal, more dysregulated behaviors. And of course, if it happens often enough, and this might be the kicker with BPD, our little bit of evidence says that this might be it, that when it happens often enough, if it's pervasive enough, it contributes so enormously to the person's vulnerabilities that has a big impact then on the person's chronicity of getting dysregulated. Because of course, just descriptively, the biggest difference between somebody with BPD and somebody without BPD is the chronicity of their dysregulation. Okay, or to go back to my earlier this one, when we replicated, this was a normative sample. When we did this with a BPD sample and compared it to the normative sample, the only difference was the people with BPD start between 18 and 19. They show exactly the same pattern. They're just as responsive to being validated. They're just as responsive to being invalidated. They show exactly the same pattern. They just start more distressed. Okay, so now I'll go back to simplify again. So the big part of the problem might be this dysfunctional two-step problem of inaccurate expression and being misunderstood and then invalidated in a variety of different ways. And of course, the big part of the solution might be a healthy two-step alternative of accurate expression and being understood and validated, which seems to help then feedback and keep the person regulated, feeling close and understood. So the role of family functioning is what we set out then to try to figure out. So if we wondered if we work on one side of this transaction, okay, the transactional model says there's this bidirectional effect. So if the patient improves, that ought to have a salutary effect on family functioning, which in turn ought to have a beneficial effect on the patient. And so we looked and said, okay, is that what happens? So we did a basic study. We had a randomized trial already going on, comparing DBT to a psychodynamic treatment, which is not the point of my presentation at all. Got up to 12 months of treatment, well controlled. The outcomes, which are published already, show that both treatments actually, on most dimensions, did pretty well. DBT did better. That's the basic idea. The yellow is the DBT, the red is the psychodynamic. The suicidality, you can see DBT has a bigger impact at the 12-month end of treatment mark and in the follow-up period, although it's a significant improvement for the psychodynamic. Social adjustment improved significantly in both, but more in DBT. Depression improved in both, but more in DBT. And family distress and dysfunction improved in both, but more in DBT. But the question is, what's driving what? Okay, the arrow's going in both directions, but is something driving it? And so we did a mediational analysis using standard hierarchical linear modeling techniques. This paper is actually now in review, so if you're interested, I can give you a copy. The idea would be that early changes in family functioning were used to predict later post-treatment and follow-up outcomes for the patient. And in fact, the results showed that in fact, there is significant mediation of outcome for suicidality, okay? Both self-harm and suicidal ideation, and for social adjustment, and surprisingly, not for depressive outcomes. That's a bit curious. I don't want to take the time to discuss that. But what that means is that regardless of treatment, if family functioning doesn't improve along with the individual, there's no feedback, there's no reciprocity, and it deters and limits the individual from getting better, as much better as otherwise. So family functioning is very relevant to patients in treatment for suicidality and self-harm, regardless of type of treatment. It mediated above and beyond treatment effects, it's mediating outcomes. So when you do a mediation analysis, you covary out the treatment effects. So it's irrespective of DBT or psychodynamic treatment. So the relationship of family functioning to depression is more complicated, which might have to do with a variety of things that I don't want to spend the time on. I just wanted to also show you, just to set Lucy up a little bit, is that if we look at standard DBT, and then add family functioning when treatment isn't all that isn't all that effective, this is what happens. Here's a trial. Now the red line at the bottom shows DBT was very effective at reducing self-harm, but not as effective for this patient in terms of use of drugs and cutting urges. Okay, so urges to cut or urges to use drugs, that's the blue, or treatment interfering behavior, that's the green. So this was 10 months of just DBT for the individual, and then as you can see the yellow arrow, we added 3 sessions of family intervention. And so some things were already way better, the red line, self-harm, but then boom, these other things got well into the normal range. And we did a whole series. I'll show you one more. This was somebody who was not self-harming, had intermittent suicide attempts, never had a suicide attempt again after starting treatment, so there's nothing to show there. But suicidal ideation, as you can see, really didn't come down for a while. And drug use didn't really, drug use is a little more complicated, and gambling was a problem. And of course, we learn, right? So we add family interventions earlier. We don't wait for 10 months, and boom, same kind of thing. Now, of course, there are some cases where DBT is sufficient without adding family interventions, but by adding it in these recalcitrant cases, we get a bigger bang. So intervene earlier with family members, and it's good for both. So parents and partners and families are very relevant to patient outcomes. Patient outcomes are very relevant to family members, and Perry certainly showed us strong examples of that. And there's a lot of support here for this idea of a transaction, and specifically, the family functioning around the mechanism being accurate expression and validation instead of inaccurate expression and invalidation. I didn't have time to show you that, in fact, we've arranged a whole bunch of different family interventions. Perry referred to family connections as one of them. Overall, they typically show very large effect sizes. Family connections, of course, has been published, a number of studies published that show big effect sizes, especially for the participant. And so, of course, what's going to happen now is Lucy's going to tell us about the implications of that for the patient when the parents are involved in treatment. And of course, we need some longer-term evaluations. We have some 6-month post-treatment kinds of things, but we need to start acting like Anthony and get 5-year and later good outcome data to know what happens much more long-term. Okay, so thanks very much. I want to now introduce Dr. Lucy Payne, who is going to tell us about a randomized trial for parents and the impact of family skills training on parents, on the kids.